YouTube Live. This is Keith coming at you from my home office here in the suburbs of Minneapolis, Minnesota, where we had a high of 95 degrees, if you can believe it, the warmest day of summer. I know that those in the South are not feeling sorry for us Minnesotans, but this is a challenge for us, and just had a really good day and looking forward to spending some time with you tonight talking about tonight's topic. Ask me anything about clinical judgment to prepare our students for real world clinical practice. And if I just want to just know who's out there tonight. So basically, if you want to throw your name and your and information in the chat, let me know that you're out there and where you're coming to us from. And my goal is to answer any and all questions related to clinical judgment and really what are the splinters in your brain that are keeping you stuck or that you're just not sure of as far as how do I move forward to bring needed change to my classroom, my clinical. And if you're an everyday educator in the trenches struggling to teach nursing and you're just experiencing that gap, that disconnect between how nursing is taught and practiced, you're wondering, why are we still doing so many pages of clinical paperwork and NANDA care plans and a precisely worded 3-part diagnostic statement? You're not alone, and we need to be part of the needed change. And every one of you who are listening to this or watching this at a later time are part of the needed change that I too experienced in my journey over 12 years ago. And if we haven't met, my name is Keith, and I'm a passionate nurse educator who has a business called KeithRN that's committed to serving the needs of educators to bring about needed change. And again, to kind of take our focus off of the NCLEX and bring it back to where it belongs, putting practice first and making it bringing perspective, to bringing back this perspective that nursing education is all about preparing our graduates for real world practice. And if we put practice first, preparing for practice, using practice informed frameworks such as the nursing process and Tanner's clinical judgment model, the NCLEX will take care of itself. And so I'm just glad you're here, and just want to kind of catch up on some last month's business. I just want you to know that every Facebook Live lives forever, in essence, on the internet. And we had a wonderful talk last month with some educators from Endicott College in Massachusetts who talked about basically bringing innovative classroom strategies to better teach and develop problem recognition skills in the classroom. And so if you missed that, that's the link that you can check that out. And I also, all of these YouTube lives that I do, as well as other topics, I've probably been doing YouTubes for way too long, almost 10 years. And the bottom line is that I have a YouTube channel, Think Like a Nurse. Please subscribe if you haven't already, because whenever new content is created, or even a Facebook Live that you missed, the recording, again, lives in posterity. And so, again, this is to serve your needs. And I just want you to know that I have those resources out there for you. And so other than that, what I just wanted to kind of prepare ourselves for the Facebook Live tonight, talking about the NCLEX, just a little introduction. I am blessed to be an admin for a Facebook group called Teachers Transforming Nursing Education. And some of you are members of that. If you are, please share what you find most helpful. But there was a post just the other day talking about where are you at with your NCLEX pass rates. And what's really interesting is that the sky isn't falling in nursing education that we kind of were expecting with the next gen NCLEX. In fact, I am totally flabbergasted that according to the statistics, the second quarter NCLEX pass rates have gone from approximately 82% last year's second quarter to 94% this quarter. And I'd love your feedback. Those of you that are watching live, what are your comments or thoughts as far as why isn't the sky falling? Why did we see this incredible bump in the NCLEX pass rates? And if you have some thoughts or comments, there's a wonderful post in the Facebook group that I'll be blogging about next month, but I would love to get your feedback for those that are here, because what I want us to kind of remember is this really important dynamic that we as educators You know, the NCLEX, and again, first-time NCLEX pass rates are how our programs are judged, for better or for worse, by the state boards of nursing. I am not a proponent of that single metric. I think that needs to change to bring needed change to nursing education, how it was taught, because we put too much, we're too myopic. NCLEX success is the topics of our conferences, NCLEX, next gen NCLEX success, and all that goes with it. But we've lost sight of practice. And there's one article that everyone who's watching this and is interviewing live need to read. It is an article called A Crisis in Competency. And this is a follow-up study done in 2021. It's an online journal article, but really what it highlights is this paradigm. Just because graduate nurses pass the NCLEX, most are still not prepared for real-world practice. They do not possess the clinical judgment skills needed for safe practice. And according to the Kavanaugh and Sharpneck study, there are educators within the Cleveland Clinic system in the Midwest, over 100 programs that they have graduates, over 1,000 a year onboarded every year, graduate nurses who pass the NCLEX. They do a simple problem recognition scenario as part of their introduction work to the system. Less than 10% of graduate nurses can do two things in their most recent numbers in 2020. They can recognize a problem and then know what to do to intervene. In 2017, that number was 23%. It went from 17 to 13 and now 9%. Now that was before the next gen NCLEX. And the big question mark is this: do these improving pass rates and the emphasis of clinical judgment translate to practice readiness? I'd love your thoughts on that. You know, if you have some comments or just you'd like to throw it out there, I've got the chat right in front of me here and would love your feedback on that. But you know, my passion as an educator is, again, I never left the bedside. As a practicing nurse, I was blessed to have a Baylor weekend position, but we need to make a focus of preparing our graduates for real world practice. And that's the next paradigm we must embrace. And every one of you listening to this need to be a part of that and looking at what we can do differently to change the way we teach. And you know, case studies and what they represent as a pedagogy to teach nursing, I think that's one of the reasons that we're seeing basically an increase in some of the NCLEX pass rates in what that represents is that case-based curriculum using unfolding case studies is a powerful paradigm shift that can, again, apply and contextualize knowledge to practice. And if you'd like to see, you know, one of the things that I've been doing with KeithRN for the last 11 years is creating the most realistic clinical reasoning emphasis case studies that, again, simulate clinical realities in ways that's unlike anything in the marketplace. And if you'd like to check one of those out at your convenience, please do so. I've got a free case study on my homepage of KeithRN.com. If you just opt in, you'll see that you'll get a download link. Put it to use and see kind of the difference that, again, using case studies that use open-ended questions, not multiple choice, because even the NCLEX with Next Gen, those complex items are still multiple choice. And practice thinking is always open-ended. There's no multiple choice or guess. Your patients don't have a two-column matrix on their head. They either know it or they don't. And that's the kind of thinking I've tried to incorporate with the cases that I've written, and I commend you to them, and check it out on KeithRN. And so as we get started on today's Facebook Live, I would love those that are watching live, put your question in the chat. Unfortunately, this is, we're not able to have a verbal dialogue, so I need to basically get it by chat and then have the opportunity to respond and have a back and forth. I'll put the chat comment or question on the screen, and then I'll be able to basically, we can have a dialogue. And I want to get your feedback as well. You know, one of the things that I wanted to do with this Facebook Live tonight, we had technical difficulties last week. And so we're repeating the same topic since it didn't even go out to the live stream on Facebook and was kind of messy. But I'm thankful that we got that fixed. And here we are today. But really, the bottom line is I want this to be a dialogue. I want this to meet your needs, however long it takes. And so again, if you have those questions, you came here for a reason, please put your questions in the chat and I'll basically answer those. until I get a question or two, what I basically would just like to kind of start with is basically where do we start with the transformation that's needed to improve the way that we teach nursing, to better prepare our graduates for practice. And I just want to commend one book that really rocked my world as a brand new educator. It was called Educating Nurses, a Call for Radical Transformation by Dr. Patricia Benner, the preeminent scholar of our generation and researcher. With her co-authors, identified 3 essential paradigm shifts. It's a must read. It's still on Amazon. Please purchase it because it'll lay you and empower you with the information of evidence-based practice to change the way you teach. But 3 things that we must do to strengthen practice readiness is basically number 1, we need to contextualize our content to the bedside of patient care. That's why case studies, well-written, open-ended questions using the essence of Tanner's framework, which the NGN model aligns with. Tanner came first, 2006. NGN 2023 basically kind of copied it and added 2 additional layers to it. That's about it. But the bottom line is that we need to bring context to our content. We just can't be giving our students all this information. And so again, if you're joining me live, I just want you to know, put your questions, comments in the chat. I'm just going to share some practical strategies that can help you in those common questions that I have gotten at conferences as well. So until I get a question, which I'm still waiting for, so please put them in the chat. Don't be shy, and love to get that information. So, which is why you came here. This is tonight's focus. Ask me anything about teaching and developing clinical judgment. But again, as I was just sharing from Benner's work in educating nurses, we got to bring context to our content to really, again, strengthen and develop clinical judgment. Because clinical judgment, if you think of it this way, it's a skill that needs to be practiced. But like any skill, like sterile technique, it needs to be repeated over and over again. And that's where our classrooms, bringing active learning, case-based learning, replicating clinical realities, contextualizing our content to the bedside is such a win. Case studies must be the foundation of active learning. And that's really why I embraced case-based learning and case studies as a new educator. Benner's work advocates it because when you look at the paradigm shifts, contextualize your content, bring clinical and classroom learning together. Bring clinical realities to your classroom. Again, a well-written case study does that better than anything else. And then bring classroom essential knowledge to your clinical. The knowledge of pathophysiology applied to practice, for example. We have a circle, and we can't just have them in silos. They've got to intersect. And that's another paradigm shift we must do differently as nurse educators. Third paradigm is emphasize clinical reasoning. There's multiple ways of thinking, Dr. Benner says, but we need to emphasize clinical reasoning. And clinical reasoning is really that thinking in action skill that takes place at the bedside. It is, in essence, the essence of Tanner's framework of those noticing skills. What do you notice? What is your interpretation of what's most important? Then how do you respond as a nurse with the priority and the plan of care? And then again, the evaluation, the reflecting of what you need to do differently or what is next based on what you've noticed and interpreted. And it repeats all over again. So even the NGN model and even as well as Tanner's framework, those individual steps are reasoning steps, clinical reasoning steps that get us to the outcome or the end result of a clinical judgment. And one of the questions that I often receive is, how do you define clinical judgment? And clinical judgment is in essence an outcome or an end result when your students can do 2 things. They can clinically reason by applying and using knowledge to the bedside, but they first must be able to critically think. And the essence of critical thinking, according to Potter and Perry's Fundamentals of Nursing, and I love this definition, is a student's or a nurse's ability to think clearly, precisely, and accurately, and to act on what you know and understand about the situation as well as the patient. When you look at, do your students understand the content? Not just memorize it, not just regurgitate the knowledge, but do they understand? Because understanding lays the ability for them to then use it. Because, if they don't understand it, they won't be able to reason with it and apply it at the bedside where it matters most. That's why our classrooms, we need to raise the bar. We need to bring that active learning and what that looks like. Because, my students, I don't know if yours are the same way, but they could tell me that atenolol was a beta blocker, but you really know if your students understand pharmacology, if they can tell you what a beta blocker is blocking, what an ACE inhibitor is inhibiting, what a calcium channel blocker is blocking. And that's the level of understanding our students must possess to be safe in practice and to have the clinical judgment needed for safe practice. So again, how do we teach clinical judgment? We've got to make sure that our students understand the knowledge and the content that we're teaching, but sometimes we're part of the problem. We give them too much information. We're just the fire hose of a textbook. Our textbooks don't do us any favor. They're over 1,000, there's thousands of pages. About half or less is really need to know for first-year generalist practice. And it's up to us as educators to filter it. Lighten the burden of your students who are bearing the burden of the readings and the knowledge expected to know. And you know what? If they don't have a deep knowledge of what's most important, it's merely memorized, forgotten, and unable to use it. And that's the challenges that we face. And so if you're joining me here live again, this is again your questions related to clinical judgment. And so for those of you that are attending live, this is your platform. I'm here for you to answer your questions or challenges that you're facing regarding teaching and developing clinical judgment. And so I'm just kind of sharing some questions that I get from educators as I'm just waiting for questions in the chat. So again, don't be shy, put them in the chat and I'll be looking for those as they come up. And in the meantime, I'll I'm not going to ramble, but I will share some things that I see as the most common themes as I've been blessed to speak around the country. I was just at the Nurse Educator Conference in the Rockies in beautiful Breckenridge, Colorado, nestled in the Rocky Mountains just a couple weeks ago. And I asked this very same question. And one of the questions that educators had that I thought was very insightful: how do you evaluate clinical judgment in real time? And we look to test. That's a great question, by the way, and there's an answer. As we look at evaluating clinical judgment in real time, that's where your classrooms, using unfolding cases with open-ended responses, can be a win. Because in essence, if you think of it this way, you have a scenario, where you have a patient scenario, like for example, an exacerbation of heart failure. And there's data in this simple 1 or 2 paragraph scenario of the patient, has shortness of breath, increasing with exertion. They are unable to sleep at night and need to have 3 pillows in order to then sit upright. And you don't tell them it's orthopnea, you just describe it, what it looks like practically. But then you ask the very first reasoning question as an open-ended response. In this scenario, what do you notice that is most important? But again, they need to look at that scenario and they have to use their open-ended thinking, recognizing their knowledge and understanding of the content to basically select what is those list of things that they need to notice. And how you can really evaluate clinical judgment in real time is when you use a case study, either break your students in small groups, or if you do it in a large group. When I did my teaching of case studies 10, 12 years ago, I had 80 students and I didn't break them up. We kind of did it in a big classroom Socratic discussion and really just pulled students from all around the room and asking and encouraging feedback. But the bottom line is that if students miss something and you say, we got this, and this, but there's 1 or 2 items that they didn't notice. Like, for example, that line that needed 2 pillows. to sleep at night. So they, in order to sleep, they had to have 2 pillows and having that head of the bed elevated. If they miss that as a group, and you're just kind of, again, the guide on the side, the bottom line is that you can immediately recognize my group missed it. My group of students missed that. Did I not teach it well, or did they not read their readings? It's kind of like, what was it that drove that? So the bottom line is that, how you can evaluate before because our goal as educators is this: we want our students to be successful on the test. If we use active learning, case-based learning, that replicates the essence of the steps of the NGN with open-ended responses, we can promote the Socratic dialogue, the open-ended thinking of practice. And if they miss something, then we can immediately correct them, say, what about this? What does this mean? Kind of ask the why question, like, well, what about this? And see if anybody kind of takes the hint. Then you can build on that. But again, you can evaluate in real time using open-ended responses. And that's why I really think that using NGN-style questions in your classroom as a teaching tool, I would flip it. Use the bow tie, use those alternative items, use the 6 questions and the 6 steps that capture the essence of Tanner's framework. But the bottom line is, make it Socratic. Don't complicate it with a 3-column matrix. There's no need for that as a classroom teaching strategy, because that's not practice. You see, if we have a paradigm that we embrace as educators, that my job is to prepare you as a student for practice, you're going to teach differently. You're going to look at everything you do differently. And that's what KeithRN has been all about for 11 years, as I saw the gap, the disconnect between how nursing is taught and practiced, and decided to do something about it, and just kind of just had a webmaster build a website, began to just share my case studies and other handouts, and it's just been blessed to grow and to serve your needs as educators. And so again, if you have questions regarding clinical judgment, that's why we're here tonight. If you have a specific question, please pop it in the chat and we'll get to that. Other than that, I've talked about how to best teach clinical judgment, evaluating it in real time. We've looked at the definition of clinical judgment. One last point I'd like to make, if there's no other questions, is basically this question: is the nursing process still relevant to teach clinical judgment? When Benner talked about multiple ways of thinking in her book, Educating Nurses, A Call for Radical Transformation, the bottom line is that there's more than one way to think. It's not just the NGN, which is really an evaluation and measurement framework, not meant to teach students. That's a faculty tool to write test questions, done. We should not be teaching our students the language of the next gen model. It's not practice informed. I mean, when was the last time you used the words hypothesis or cues as a nurse? I haven't done it in 36 years. I don't think any of you who are listening have either. So let's not teach our students and exacerbate this disconnect between practice and academia. And so as we look at that, just want us to kind of just, again, look at the nursing process. Look at it this way: it is still relevant. I have taken a very strong position, as has the American Nurses Association. The nursing process is still relevant to clinical judgment and to thinking like a nurse. It's only one way. It's a linear framework, but it's a foundational and it's a fundamental framework that our students need to start with. So when you have your first semester fundamental students, they must start with something. And that's why we need to start with the nursing process. But then we need to build on it, kind of like you have every house has a foundation, but then it's built upon with the walls and the roof. And the walls and the roof are the essence of Tanner's clinical judgment model. Because the beauty of Tanner's framework, and let me just kind of share just one little infographic here that ATI gave me permission to share, is that when you look at Tanner's framework, that is the outer edge of this circle, the noticing, the interpreting, and then the responding as a nurse, and then the reflecting, which is evaluative reflecting. Look at how the nursing process in the middle aligns. That assessment of the nursing process aligns with noticing. Oh, and by the way, look at recognizing cues. The inner circle, which is the NGN model, aligns with all of the above. So this infographic understood will empower you as an educator. Don't teach to the test. Don't teach to the NGN model. Don't teach your students the NGN model unless you really want to teach to the test, which I don't think any nurse educator really wants to do. That's not why I became an educator, and you didn't either. You sacrificed salary and time to make a contribution to the next generation of nurses. But again, we have to innovate. We can't allow the current culture of nursing education to basically put us into that mold that is all about the test in too many programs. And again, we have to resist that. And we need to, again, do what is needed for such a time as this. And so I just want to share this infographic to show you that, assessment, for example, when we teach assessment of the nursing process, for example, we want to then basically build on it by then bringing in Tanner's framework, saying, okay, you did your nursing assessment, which most students will still see as a skill of doing an assessment because they're concrete task-oriented learners. Okay, let's just give them that grace. They see assessment as a skill first. They need to do it head to toe, collect the data, write it down. But then we build on that assessment by asking the first step of Tanner's framework, which also aligns with the NGN of recognized cues. By the way, when you did your assessment, what did you notice that was most important? Or we could ask the similar question, what did you notice that was most concerning? Or what did you notice that was not expected? You see, all of those questions align with noticing, the very first step of clinical reasoning that leads to the outcome of clinical judgment. As you work through the steps of reasoning, noticing, aligning with assessment, the analysis or meaning of what that data means. Then how, as you collect and understand that, but remember this, in order to really interpret the data, know what it means, your students must understand pathophys. And most students struggle with that, including educators. And that's where we've got to step up our game to better teach pathophys applied to nursing practice so our students can interpret the meaning with confidence. Because if they don't notice or they don't interpret correctly, you're going to have failure to rescue. A problem or complication will go unrecognized, like sepsis, going to septic shock, and that tachycardia, that heart rate increasing over time goes unnoticed while the blood pressure is compensated, and then the toilet swirl begins and their pressure drops precipitously and they are near death. And for some, it's too late. And I know that for me, as a rapid response nurse at a large metro hospital, I've seen that happen more than it should. And the consequences lead to a dead patient in a body bag that didn't have to die. And so let's just remember in closing that nursing education isn't Vegas. What happens in nursing education doesn't stay in nursing education. The bottom line is that our students are going to graduate and they're going to go into our practice settings. And if they're not prepared, bad outcomes and patient death that could involve you or a family member are the outcome. And so I just want to say thank you. I see that Diane Fairchild. Thank you, Diane, for just sharing a comment here, a question. And let's just look at it live together here. And let's look at this together. She says this: we do have wonderful clinical adjunct instructors, but some focus more on medication passes and skills. What are your suggestions for getting buy-in to emphasize clinical judgment? Diane, that's a really great question. There's some implications here that we need to give our new adjuncts grace for. Number one, like Benner's novice to expert theory tells us, and I was no different as a clinical adjunct, a new nurse and a new adjunct see the tasks of nursing as preeminent. The more tasks we do, the more I feel like a nurse. Or if I'm a clinical instructor, the more med passes, the more skills we do, dropping an NG, put in a Foley catheter. That was a win. Everybody saw it and yay. Well, yes and no. But the bottom line is this. It's not so much about getting buy-in, Diane. What it really is, it's about educating our adjuncts to really give them the tools and the resources to understand how to teach clinical judgment, how to transition from an academic, from a clinical expert to a novice educator takes time, experience, but more importantly, good training. And Diane, I would encourage you to look at the training processes in your program. How are you onboarding adjuncts? What tools are you giving them to set them up for success? What teaching, what articles are you sharing? You know, we don't do a really good job in nursing education, in my opinion, with developing faculty. The resources, even from the big vendors, are lacking. Yeah, that's another problem we need to fix. And I'd love to do my part to be part of that change. I do have a membership platform, Diane, and I have numerous resources handouts and tools for empowering educators to teach and apply clinical judgment, the knowledge of pathophysiology to practice. And it's called thinklikeanurse.com. And I've got a coupon code for an individual membership, but I also offer program memberships at a dramatic discount that provide clinical faculty with teaching and training with accredited CEs, as well as the tools with concise worksheets, even examples of clinical judgment paperwork, only 5 pages, that can rock and reinforce clinical judgment. So Diane, if you'd like to learn more, no pressure. This is not a sales pitch. I just want you to know that I have some tools that can strengthen how you are developing and providing tools for your adjuncts, as well as all faculty, to teach and develop clinical judgment. And if you'd like a program quote, no addition, at no obligation and no pressure, glad to provide that to you. And so use the second link there if you'd like to learn more. And yes, and so Diane, you know, it's really not about buying, it is about preparing our adjuncts. And sometimes we're just glad to have enough, but we need to teach them, Diane. And so that really is the challenge. But again, you, Diane, can be part of the solution. And so again, do your part and what that looks like. And so, yeah, you know, thank you for your interest in the membership and complete the purchasing process. So if you've started that, Diane, yes, to strengthen and improve practice readiness. And that's kind of why I've developed the membership platform, Think Like a Nurse. And again, for anybody who's interested, thinklikeanurse.com. And you can see what I offer there to serve your needs in both classroom and clinical teaching. So what other questions are out there? Diane, thank you for asking that. Great question. I would love to know. There's usually about a 20 to 30-second delay. So pop it in as soon as you are able, so there's not an uncomfortable silence. And I don't have to do anything more to try to fill in the time. But I do want you to know that, you know, even though we're facing numerous challenges, and I would say that, you know what, I would encourage us as educators with this thought: just because the NCLEX and Next Gen wasn't the disaster we thought it was going to be with NCLEX pass rates, and we're seeing programs across the country in the Facebook post as well as the NCSBN stats, 94%. Who would have guessed a 12% increase with a more difficult case-based clinical judgment emphasis? That was never expected. It's kind of like, boy, I'd like to know the P factor of that for significance. But, you know, the bottom line is we must not rest on our laurels and think, oh, just because, oh, the sky didn't fall. Oh, good, we're fine. Because our students still aren't prepared for practice. And we need 6 patients or more. You know, they don't have 1 or 2 patients in practice unless they're in ICU, and most of our students will not start there. How are we preparing our students for multiple patient assignments, for the time management, and the transition from a head-to-toe assessment to a focused assessment? How many skills are you teaching in nursing assessment? We're teaching in many programs, according to the literature, 120 on average, when a nurse uses 30. We're teaching too much. We have infobesity in our curriculum. We must cut the fat out. So we're teaching need to know, practice knowledge, and not just academic textbook information. Let's put away the tuning forks and the reflex hammers once and for all. Bury them, get rid of them, teach practice-informed nursing assessment. That is the bread and butter, the core of practice. So again, just some thoughts, kind of unhinged from my perspective, but I'm really tired of just seeing these ongoing disconnect between how nursing is taught and practiced. I'd love your comments on that. Why is there a disconnect between practice and academia that is lingering? You know, what's really interesting, when I did my dissertation study and did my lit review, looking at the academic practice gap as one of the components, the disconnect between how nursing is taught and practiced has been documented in the nursing literature since 1974. If you're counting, 50 years. That is not okay. You know, we have got to bring that down to zero. We have got to do something that hasn't been done in 50 years. And every one of you, again, can be part of that needed change. And I am going to lead that charge. I'm going to lead a movement. My passion with KeithRN is to lead a movement to challenge the status quo that is sick and unhealthy in nursing education for way too long. And we've got to really make it all about practice, that our predictive testing needs to predict practice readiness, not only NCLEX success. That's part of the problem as well. But I'd like to know your thoughts. What do you think is part of the problem? What questions do you have relating to clinical judgment? Just some of the thoughts that I have, and I just want to thank you for listening. But as we look at, in closing here, I don't see more. I'm going to keep the chat open, but I'm going to wrap this up here. But I will just kind of share some thoughts in closing here. Is that, you know, if there's one article that I would love you to read besides the article Crisis and Competency, every educator must read Tanner's original framework of thinking like a nurse. This is the foundation. That the NGN is, again, the egg. Tanner's clinical judgment model is the chicken, published in 2006. And it provides valuable foundational knowledge that really provides more than just 4 steps of clinical reasoning, but it provides, in essence, a holistic approach to clinical judgment. Because one of the key takeaways, and this is why every educator must use Tanner's framework to inform their teaching of clinical judgment, is because it came from practice, over 200, almost 200 articles that Chris Tanner synthesized from nursing knowledge and theory, not psychometric test language. And what Tanner identified was some assumptions about clinical judgment. And I love her first assumption that she identified as one of her themes. And it's so important for you to know this and to read the article yourself. But that clinical judgment is influenced more by what the nurse brings to the situation of the patient care than the actual situation itself. Now, what she's saying in essence is this: what do you possess as a nurse with your caring, your compassion, your empathy, your desire to be the best as a nurse? That heart, that motivation of what you bring, your knowledge, your excellence, is going to influence the right decision more than the actual situation itself, and what you notice, and then what you interpret its meaning, and then how to respond. Because in essence, what Tanner is saying that we're losing in nursing education is this: in order to think like a nurse, developing the clinical judgment for safe practice, you need to care like a nurse. And, we're losing that virtue ethic in this generation. And we must remember that if we lose caring, we've lost something precious that we will not recover from as a profession. And I'm fearful because we live in a hostile postmodern culture that is antagonistic to the values, the Judeo-Christian values that nursing has been predicated upon for 2,000 years, primarily caring and compassion. And those values can be seen as relative, by the way, in this generation, if we're not careful, if we're not intentional to teach them to this generation of students. That's why every educator who's hearing this needs to take this to heart, because if we need to make visible, we need to role model caring, we need to communicate that caring in all that we do, but we also need to make it visible to how do you care like a nurse? And what does that look like? What does holistic care done well look like? And I just want to encourage us as a profession that if we really care about the next generation of nurses that are already stressed and entitled and tends to be pretty self-centered, which we all can be, all of the above, they're no different than us. But the bottom line is we've got to make it visible. We've got to make it intentional, or we're going to lose something precious and we will not recover from it. And I'm fearful. And so I don't know if anybody else shares that sentiment. But, that's why I'm passionate about it, incorporating caring. And, one of the best definitions of caring as a nurse by Dr. Patricia Benner from one of her earlier works called Primacy of Caring was that the essence of caring as a nurse, she wrote this in 1989, is that the patient and their experience matter to you as a person and as a nurse. That's just not a room number. It's not just a diagnosis. That person matters to you because they have value, whether they're homeless, whether they're an addict, whether they have whatever, stigma. They're a human being of infinite value and worth that God created. Therefore, we care for them, and we provide that empathetic care that has grounded us as a profession for 2,000 years. Nightingale was merely the modern era. It existed since the early church in the very first century. That's where caring, compassion, and the essence of our profession began. That's in the nursing history, by the way. That's not according to Keith. So again, we need to look at that bigger picture, make it visible. And so I would just encourage you in closing to ask these questions to your students. We ask the clinical judgment questions. What do you notice that's most important? Great question. First step of reasoning. But how about this question based on the definition of caring that I just shared with you? Ask this question to your students. What can you do in clinical today to show in a tangible way that this person matters to you? To show that they have value and worth. What are you going to do as a nurse? Not just provide their medications, not just do their vital signs. What are you going to do to communicate person to person? You matter to me. We're losing that. And we've got to recapture it, or again, we've lost something that will not be retrieved. And so let's just make those things intentional. And that's where, again, every one of you listening to this can be part of that needed change and can do what is needed to provide to demonstrate the caring, to help your students, again, have the clinical judgment, the practice readiness. How we teach nursing makes all the difference. If we transform the way we teach, we can move the needle and we can bring about the needed change that we need in nursing education. And so I just want to close. So Diane, let me just kind of, glad to have your feedback. And let me just I'll just put you on the screen, Diane. Let's share your thoughts with the world. She says, that is such an important aspect of caring that needs to be in the foremost of our minds. The same diagnosis may not cause the same fear or concern for one person that it does in another person. And absolutely right. We need to get, again, we can talk about, even like, the essence of CUSIN, patient-centered care. You see, when you look at the ASIN essentials, what's another primary concept or domain? Patient-centered care. You know what that patient-centered care is really showing? The patient is preeminent. The patient matters. Individualized patient care. And again, doing our best as nurses. Again, we're not perfect, but we do our best to, again, come down to that person-to-person level, and again, demonstrate that empathy and that care that is distinct to our students or to our patients. And again, that's how nurses make a difference. That's why we're the most trusted of professions. And we've just got to maintain that centrality. And, for me, I'll never forget, at one program I taught at, in our mission statement, we wanted, caring, we wanted caring nurses and compassionate caregivers as part of, our mission as a program. But when I looked at the curriculum, there was no curricular intentionality or integration of the importance of caring, the history of our profession that contextualizes care and compassion, which is the essence. A good nurse is also a good Samaritan. And that's the essence of where caring and compassion became the primary virtue ethic of our profession, as we provide compassionate care to those strangers, even despised ethnic minorities, which is the parable that Jesus told 2,000 years ago. Samaritans were the despised half-breeds. The Jews were purebreds, were purebreds in their own mind. They're both human beings of equal value. But the Samaritans were half-breeds, half Jew, half Gentile. And they were not well liked by the Jews. And it was the Jews who looked over the other side, but it was the Samaritan, the despised ethnic minority, who saw the person. And the story, Jesus said, moved with compassion, provided care, and that's really, I guess I think it's an important point to close with. A good nurse is a good Samaritan. Even Dr. Benner has affirmed that in a speech that she gave over 10 years ago. I don't have it in front of me, but she, again, basically kind of called us as nurses to provide that compassionate care as a good Samaritan to those we do not yet know. And so, again, let's recapture that. And again, let's make that a priority of all that we do. So thank you for sharing, Diane. Great to have your feedback tonight. As I shared before, with KeithRN, if you're looking for resources to teach and develop clinical judgment, if you look in this chat at the very beginning, I did share a free case study of a next-gen reasoning. If you're looking for resources to innovate your classroom and clinical teaching, again, my gift to you. I've also got numerous blogs and articles on my homepage on KeithRN.com. If you go and just see the link at the very top as it relates to articles. I've been blogging for almost 10 years, about 200 plus articles on everything under the sun, including some of the current challenges and dilemmas we're facing. So again, if you're looking for additional free resources, you have the Next Gen Reasoning, as well as my YouTube channel, Think Like a Nurse, as well as then, just want to share one more time in closing, my flagship resource, KeithRN, is basically the faculty membership, which is, again, a unique resource that doesn't charge students to access the case studies. That's unheard of in nursing education today. And to me, I want to give faculty the best resources, but then I also provide the link for students to download the student version of an unfolding case study, as well as a template to write it in, while faculty get an answer key and a PowerPoint, which I don't think any other vendor provides. And again, my passion is to make life as simple for the everyday educator who is time-strapped, and what that looks like, because I was there. And I didn't find the resources by the textbook publishers that strong. I wasn't impressed with their case studies. They were multiple choice, knowledge-based, and we need to do better. And so I decided to build a better mousetrap called my best attempt at unfolding clinical reasoning case studies, and again, other tools to make it real, bringing practice emphasis back to nursing education, preparing our graduates for practice. We must recapture that. And I hope that every one of you will carry that torch, that banner, as you begin your programs. If you've been blessed to have the summer off, Take that torch, bring it to your program. To again, let's talk about practice readiness. How are we really doing there? Let's look at simulation scenarios that have multiple patients, not just one, but three. That would be a good start. And priority setting with 3 patients. And basically throw in some curveballs, make it real. We've got to prepare our students, because the problem is they may pass the NCLEX, they may graduate, but the attrition rates of our new graduate nurses is atrocious. It's up to 33% after 2 years. They're gone. And they're not even in nursing anymore. They just dropped out and went to something else. And that's part of that. That's on us. Part of that is on us as educators, because we have to prepare them like a drill sergeant preparing their recruits for battle. We got to prevent them from being roadkill. That's what a good DI does. And we as educators need to have a kindness, though, not be the brute DI, drill instructor, but again, having standards, expectations, as well as willing to fail students who should not pass. There are some students we pass that should not. And again, it's all about the patient. And if we maintain a patient-centered perspective in nursing education, teach that to our students. It's all about nursing is about serving others and being the best for them, not just good enough to pass the test. And as educators, we need to hold that and remind our students of that daily sometimes. But we must not let the inmates run the asylum in nursing education, which from what I hear is happening. Students have too much power. And again, I'm all about kindness, compassion, and fairness, but we must hold the line and do what is right and best for the students, preparing them for practice to provide safe patient care so they don't kill their patients. That's the bottom line. And if they're not prepared, we have patients in body bags. And I've seen it. You've seen it. You know what I'm talking about. Let's bring the patient back to patient-centered care, and making that not just a nice little thing for our ASIN domain or our QSIN essentials. It's what we do in nursing education. So anyways, it's been fun to just kind of share this with you all tonight. Thank you again for your time. And if you have any questions, last call, kind of like a last round, last call for questions. And again, thank you, Diane, for sharing tonight your insights, and for just those that have stayed to just, again, I hope my heart is that this landed on good soil. I'm not just ranting here. I'm sharing my heart, my passion that I know is similar, if not identical to yours, that I have kindred. You're here for a reason. And I just want you to percolate on the things that I'm sharing. Maybe a little different than what you've heard from the party line or from other educators at conferences, but I'm just Keith. I'm just who I am. And I have my unique lens and perspective and my values that, again, I think align with most of yours. And so again, thank you for just giving me this opportunity to have a platform to share and to be listened to. And again, you are heard. And it's my passion to best serve your needs in nursing education and all that I do. And so I hope you check out some of the resources I have for you that I've shared. And just an FYI that if you'd like to learn more about KeithRN and you're just kind of saying, who is this guy? I have one last thing that's just a free thing that I do every month. Every Friday, the first Friday of every month, I have a 2-hour workshop, basically developing clinical judgment with KeithRN. It's on Friday, August 4th. From 10 a.m. to 12 noon Central. And if you would just like to, again, I'm just share some practical strategies and build on what I've shared today, but more importantly, kind of show you the elements of the matrix of KeithRN, the membership platform, the highlighting the resources on my website, and other free takeaways and other tools, as well as a free raffle for a $160 textbook set called Think Like a Nurse. That's, again, a practice-informed text series for your students to help them better understand clinical judgment. We'll talk about that. So anyways, I want to thank you for your time, your attention, and thank you, Diane, for taking notes. I hope that many of you who are listening to this or to the recording will do the same. And I hope you found this helpful. And again, my pleasure to serve your needs. I wish you the best. My thoughts and prayers are with you all. You have an important job to do. And just remember this, that you are right where you are, even though it's difficult, even though it's challenging, for such a time as this. And don't walk away, but stand firm, face the battle, and I got your back, and I will do everything I can to support you so that you can make a difference in nursing education. It's my pleasure to partner with you all. Thank you again. Have a great night. Take care.